Hello, my name is Israr Ahmed. I'm a PGY3 resident. Welcome to Think Like ABIM. This is for everyone that's preparing for their ABIM internal medicine board exam. So here is today's ABIM style cardiology question about refractory atrial fibrillation. So you have a 46-year-old man. He comes to your office. He has history of hypertension, hyperlipidemia. He's complaining of recurrent palpitations that wake him up at night. 1 year ago, he was diagnosed with persistent atrial fibrillation. Initially, he was treated with metoprolol, diltiazem, and flecainide, which provided only temporary relief. Right now, his symptoms are continuously reoccurring. The flecainide was recently stopped and switched to Sutalol. You do an EKG on the patient and it's sinus rhythm with QTC of 420. You get an echocardiogram showing EF of 50%, left atrial enlargement, and you do a Holter which shows episodes of AFib with RVR correlating with his symptoms. So what is the best next step to maintain sinus rhythm in this patient? So you can pause the video here and choose one of the following options. You have around 5 to 10 seconds. Okay, so the correct answer is C, refer for transcatheter ablation procedure. How many people got this right? Comment in the section below. Okay, so if we break this question down, we have this young patient, 46-year-old, who has a paroxysmal atrial fibrillation. He's highly symptomatic. He failed 2 antiarrhythmics, and he's still having recurrent symptoms despite these medications. So meets criteria for drug refractory atrial fibrillation. Since he's young and symptomatic, and he's a good candidate for rhythm control strategy. So the next best step is to basically refer the patient for transcatheter AFib ablation. Another thing that you can do is basically to abandon rhythm control strategy and stop trying to maintain sinus rhythm and basically switch him to a pure rate control approach with like metoprolol and diltiazem. But in a relatively young and highly symptomatic patient like this one, attempting ablation to maintain long-term sinus rhythm is actually more appropriate. So let's quickly review the incorrect options. So the first incorrect option is to add digoxin. And as we know, digoxin slows conduction through the AV node and can help with rate control, but it is not an antiarrhythmic drug. So it does not prevent atrial fibrillation episodes, and therefore it does not help maintain sinus rhythm in this patient. So this is not an appropriate option to choose. The second incorrect option is surgical maze procedure. And this is also incorrect because this is an open heart surgical procedure that is used to create scar tissue to prevent AFib. Now, it's usually reserved for patients that are already undergoing cardiac surgery for another reason, like valvular replacement, or for those who fail less invasive options. And having mild mitral regurgitation is not an indication for surgery, so this is not appropriate as well. And then, as we all know, mexiletine is a class 1B antiarrhythmic, which is mainly used for ventricular arrhythmias. So it has no role in treating AFib. So therefore, this is not our right answer. And then propafen 1 is also a class 1C antiarrhythmic drug, which is similar to flecainide, which the patient already failed. Right, so switching to another medication in the same class is actually unlikely to be effective. Okay, so basically the key educational point in this basically question stem is that patients with symptomatic paroxysmal atrial fibrillation who remain symptomatic after at least one class 1 or class 3 antiarrhythmic drug, then catheter ablation is the recommended next step to maintain sinus rhythm. Thanks for watching. See you in the next ABIM review question.